Okay, so the cardiac cycle, your P wave, you guys need to know your P wave, your QRS complex, and your T waves. You have to know that for your exam. You have to be able to identify that. So your P wave is depolarization of the atria. Your QRS complex is the depolarization of the ventricles, and then your T wave is your repolarization of the ventricles. So in the hospital, we're going to monitor this. We're going to look for widening QRS complexes. We're going to look for T wave elevation. We're going to look more in depth, but you guys just need to know the basic EKG rhythm, and then we'll get a little bit more in depth as we move forward. So your autonomic nervous system controls your heart rate, and this is your baroreceptors. These are the sensors in the blood vessels and heart that detect changes in blood pressure. They are located in the carotid sinus and aortic arch. Baroreceptors are mechanicoreceptors that detect the stretch of the vascular walls. When the blood volume increases, the vessels stretch and the baroreceptors fire more often. The brain receives this information and sends signals to the heart and blood vessels to raise or lower blood pressure. So when you see a patient, you need to get a very in-depth assessment of their cardiovascular history. So what type of health history do they have? Are they intravenous drug users? Do they have a history of hypertension, high cholesterol? You need to know their demographic information. Do they have a genetic history of cardiac disease? And then obviously they're not modifiable and they're non-modifiable disease risk factors. Within this health history, so you need to get their complaints. So if somebody's complaining of chest pain, they might be having angina. It could be stable or unstable. You need to figure out where the pain's going. Is it radiating up into their jaw? Is it going down their left arm? If they have shortness of breath, what do you think that could be an indicator of? Yes. And then peripheral edema, weight gain, abdominal distension, palpitations. That is just when somebody has the self-awareness of their own heartbeat. And then unusual fatigue, dizziness, and syncope. So if somebody's having syncope, what is that typically related to? Typically, most of the time it's related to where people like the orthostatic. Yeah. So they stand up, their heart rate goes up and their blood pressure drops, and then they hit the floor. Or some people have POTS syndrome, so they stand up and their heart rate just goes super high, and then they obviously feel like death. Your laboratory tests, so your cardiac enzymes, this is your troponin. So any patient that comes in with chest pain, we need to draw troponin. This is an indicator to determine enzymes released into the bloodstream that when the heart suffers ischemia. And then your lipid profile provides more information regarding cholesterol levels and is used for early detection of heart disease. BNP, this is a tool for congestive heart failure. And then your CRP is produced by the liver in response to systemic inflammation. So inflammation is thought to play a role in development and progression of atherosclerosis, so patients that have high cholesterol. You do need to know your LDL, your HDL, and your total cholesterol levels. Your LDL is your bad cholesterol, and your HDL is your good cholesterol. The book says up greater than 45 for HDL, but greater than 60 is typically like your cardioprotective. That's where you want your levels to be. An ECG, this is what every patient that comes into the hospital, they typically get one of these. So they can be on telemetry, and then a lot of times if patients come in and they're complaining like, oh, I'm having syncopal episodes or I can feel palpitations, they're going to wear a Holter monitor. Typically, they wear it for 1 month, and then they'll have it read, and then they can determine if they've had any type of arrhythmias within that time period. So you will have to identify EKG rhythms on your exam, and they are the ones in this PowerPoint. So if you can identify what's here, you should be able to identify what's on the exam. So this is your normal sinus rhythm. This is what you want every patient to be in. This is a rate of 60 to 100. You can see the P waves and the T waves, and then the QRS complex. And then it has a very regular rhythm. You will learn more about EKG strips and how to measure the QRS complex and stuff next semester. But you just need to be able to identify these rhythms. This is sinus tach, so this is when a patient's heart rate is above 100 or below 160. And then again, you can see your waves there.
Just going back and forth between these two, one before this and that, what's the
And then this is your sinus bradycardia. So obviously see how far this is out. So this is like a 50 beat rhythm. You have to be careful once you start getting into these rhythms. You have to start monitoring, are they in a heart block? And then it turns into stable versus unstable. So if they have a low heart rate and their blood pressure is low, do you guys know what the intervention would be? What is it? So turn down. I get it now. If their blood pressure is low, you're going to start pacing them. Or if they're unstable, and then if they're stable, you're going to give them what drug? Starts with an A. Atropine. Yes.
What is a heart block?
You will learn more about that next semester.
Because I've heard that term, but
It's very complex. So like your P waves start dropping off. It's a little bit too advanced for this class.
Okay. I think that's what we really need though.
Yeah, I can bring
break it down.
the EKG book and you can look at them, but those heart blocks, I'm still not the best with them because you have like second degree, type 1, type 2. Yeah, they're hard. this slide right here is atrial fibrillation. This is your most common abnormality with heart rates. This is commonly associated with coronary artery disease. But what makes this different from normal sinus is if you look at these, when you measure these, they should match every time. Do you see how irregular this is? That's a sign of AFib. Do you guys know what patients on AFib need to be on? Because it increases their risk for blood clots.
They could be on the
Warfarin or like a low molecular weight heparin, just to prevent. And then this is AFib RVR. This is the rapid ventricular rate. So this is over 100. And you can just see it's all over the place. Do you guys know what we need to do in this situation? Cardiovert, depending. You can try meds first. So usually we'll use diltiazem or cardizem. You'll give them a bolus and then they'll be on a drip. But typically we have to revert to cardioversion under one circumstance. Do you guys know what that circumstance is?
Why you use cardioversion?
Yes. If somebody come in with this, when would you cardiovert them? Immediately. If they're on blood thinners. Because if you just go ahead and shock this and they're not on blood thinners, you have the risk of just breaking that clot loose and then you're running into more issues. So typically they'll start them on anticoagulants for, I'm wanting to say 1 to 2 days, and then we'll start doing cardioversion if needed. Huh? And then sometimes patients, you start them on meds and then they just cardiovert like that. It's weird. And then this is a beautiful rhythm. It's not good in real life, but this is a very bad rhythm. So there's two things that you need to make sure with this patient. Do they have a pulse or do they not have a pulse? If they have a pulse, what are we going to do? Depending if they're shocking, depends on if they're stable or unstable.
Do nurses do shocking or that doctor?
It depends. I mean, if you're in a bad situation, the doctor's not there, we'll light them up sometimes.
Where you can bear down.
No, that is SVT. So if they have, we will try amiodarone bolus and then a drip, and then if it doesn't break it, typically we shock them. If they have a pulse, it is a synchronized shock. So there's a little button, and the machine will do it for you. Do not just go in there and just push shock on somebody that's in VTAC with a pulse, because you'll likely kill them. It can cause like an R on T phenomenon, and then they're done. And then if they are in VTAC and they don't have a pulse, you're going to start CPR, and then obviously you're going to defibrillate them. You're not going to cardiovert them. Make note of that. There's a difference. And then this is another bad rhythm. This is asystole. So somebody, if they're this, they're dead. Do you shock asystole?
No.
No, do never shock asystole. You're going to give IV epinephrine, and then if they're in a ventricular rhythm beforehand, there's all kinds of drugs that you can get, but do not shock this. This is CPR and epinephrine only.
Give her lidocaine.
We give lidocaine sometimes if they're in like VTAC and they don't break with amio. We'll give lidocaine sometimes, but not commonly. Any questions about these? Those are all the rhythms that you should study for your exam. I'm not saying they're all going to be on there, but there will be a few.
I'm working night shift next week.
Mm-hmm.
Would you like me to bring some samples? I can fly out.
In this slide, we're going to talk about your transthoracic echo. So this is a non-invasive ultrasound that is used to diagnose valve disorders and cardiomyopathy. It is used to evaluate the size, shape, and motion of the structure of the heart, and it is often used to measure ejection fraction. Ejection fraction is the volume of blood ejected from the heart each beat. Everybody in West Virginia has a terrible ejection fraction. It is something that can improve, but they have to be compliant with medications, exercise for it to improve. Other than that, it's just going to deteriorate. An echo is indicated in patients with heart failure, angina, and myocardial infarction. This test can take up to 1 hour, and you should instruct the patient that they're going to have to lie on their side and remain still. Left side, and remain still. I don't know how many patients I've had stress testing. This is when clients exercise their cardiac muscle by walking on a treadmill. This provides information regarding the workload of the heart. This test is discontinued once they reach a certain heart rate. Fatigue and disability may prevent from traditional stress testing, so pharmacological stress testing may be indicated. This is indicated for patients that have angina, heart failure, and dysrhythmias. Are you going to put somebody that's having a MI on a stress test? Exactly. So if they're an outpatient stress test or inpatient, so they have to fast 2 to 4 hours before the procedure and avoid tobacco, alcohol, and caffeine. This could give false readings. What is it? Yeah. So if pharmacological stress testing is indicated, medications like adenosine and dobutamine are given to stress the heart instead of walking on the treadmill. Does everybody know what adenosine does? Yeah, it stops your heart. I gave it the other day. You can literally, the patient's awake during this, and you'll literally watch them flatline for, depending on how long. It's a very short acting drug, so it hits their heart and typically it converts them right back in. So you have a stopcock system, so you push the drug, you have a flush right behind it, you raise their arm immediately, and then within a few seconds you'll just watch their heart just stop. And they describe it as getting kicked in the chest by a mule or something like that. They said it hurts really bad. You've had it done?
I've been shocked 4 times before I stopped him. It's
So during this procedure of the stress test, you have to have continuous monitoring of an EKG. Do you guys know why? So if they start exercising and they might start throwing arrhythmias, their heart rate might just shoot up immediately, and also we're monitoring their heart rate for that goal. And then after the procedure, you're going to want to monitor their blood pressure frequently just to make sure that they are stable to go home or go back to wherever they came from in the hospital. We're going to talk a little bit about a heart cath. So it can be used as a diagnostic procedure. So patients that just have chest pain or they have a troponin that's elevated and they have no evidence of an MI on an EKG, sometimes they'll just go in there and do a cardiac cath just to see if there's any type of blockages of what might be causing that troponin to be elevated. But and then we also use it for patients that are having MIs. So if they're having an inferior wall infarct, they will obviously have to go to the cath lab to save their life. And so this is obviously indicated for unstable angina, ST elevation, and then if it's used for a diagnostic test. This is used to confirm and determine the location and extent of heart disease. The patient should be NPO at least 8 hours due to the risk of aspiration with lying flat. They give them Versed, Ativan, they knock them out. They're still awake, but they don't really remember. Oh yeah, they're awake for this, but they're on cloud nine. Does anybody know what allergy we have to monitor for if somebody's going for a heart cath? Yes, if they have a shellfish or an iodine media contrast allergy, they use this during the test. So if they do, we pre-medicate them with Solumedrol, Benadryl, just to prevent them from having the reaction. It's within the contrast.
So when they do, like some cardiologists
So does anybody know what medication needs to be withheld before a heart cath? Metformin. Okay, so they should hold with metformin for up to 48 hours because metformin can cause hypoglycemia or acidosis when receiving iodine media. So it interacts with the contrast. You will see this question a million times throughout your school career. You'll probably even see it on the NCLEX.
It causes hypoglycemia.
Okay, the most common cause of cardiovascular disease in the United States is atherosclerosis, which is an abnormal accumulation of lipid or fatty substances in fibroid tissue lining the arterial blood vessels. These substances block and narrow the coronary vessels in a way that reduces blood flow to the myocardium. Atherosclerosis involves a repetitive inflammatory response to injury of the artery wall and subsequent alteration of the structural and biochemical properties of the arterial wall. So coronary artery disease or atherosclerosis, they're both the same thing. I'll probably just say coronary artery disease because it's easier to say. Produces symptoms and complications according to the location and the degree of the narrowing of the arterial lumen, thrombus formation, and obstruction of blood vessel to the myocardium. This impediment, hold on. This is usually, so the blood flow is usually progressive, causing inadequate blood flow supply and deprives cardiac muscles of oxygen needed for survival. This condition is known as ischemia. Angina pectoris, I always used to call it angina, but it's angina, refers to chest pain that is brought about by myocardial ischemia. Angina pectoris is usually caused by significant coronary artery disease. If the decrease in blood supply is great enough of long-term duration, or both, irreversible damage and death of myocardial cells may result. Over time, damaged myocardium undergoes degeneration and is replaced by scar tissue, causing a various degree of myocardial dysfunction. Significant myocardial damage may result in persistently low cardiac output and heart failure, where the heart cannot support the body's needs for blood. A decrease in blood supply from coronary artery disease may cause the heart to abruptly stop beating, and this is known as sudden cardiac death. So, prevention of coronary artery disease, we need to advise patients that they need to stop eating so much cholesterol. So we need to put the bacon away and eat turkey bacon. Dietary measures, so they need to increase fruits and vegetables. They need to get daily exercise. Do you know what the first line medication is for coronary artery disease? Statins. They need to get rid of tobacco use. Hypertension goes hand in hand. And then if they're a diabetic, they need to control this. I feel like West Virginia has the great combination of diabetes, hypertension, and coronary artery disease. They all have it. we'll touch a little bit on this, but your farm lecture will cover in depth. So what I want you guys to know is your statins. This is like your atorvastatin, your simvastatin. We need to monitor these patients for muscle cramps and weakness. Do you know why? This close. So this is caused by rhabdomyolysis. So it causes muscle weakness and breakdown, and then it ultimately can kill their kidneys. So if somebody takes a statin and they say that they are having progressive muscle weakness, they need to stop taking it or they're at risk. And then we're going to monitor what laboratory value for rhabdo. Come on, guys. It's with your kidneys, it's creatine kinase or a CKMB. So with rhabdo, what happens is your muscles break down, they release myoglobin, and then it goes to the kidneys. So your patient's going to start, their urine's going to be like a cola color, and then that's a great indication that this medication needs stopped. Let me pause this. So angina, oh, I'm running 3 systems up here, so if I get behind, just let me know. So angina pectoris is a clinical syndrome usually characterized by episodes of pain or pressure in the anterior chest. The cause is insufficient coronary blood flow resulting in decreased oxygen supply where there is increased myocardial demand for oxygen in response to physical exertion or emotional stress. In other words, so the need for oxygen outgoes the oxygen demand. So the patho behind this, angina is usually caused by coronary artery disease and most often is associated with a significant obstruction of at least one major coronary artery. Normally, the myocardium extracts a large amount of oxygen from the coronary circulation to meet its continuous demands. When the demand increases, the flow of the coronary arteries needs to be increased. When there is a blockage in the coronary artery, flow cannot be increased and ischemia results. You guys need to remember that. On a EKG, you will see an inverted T wave on somebody that has unstable angina, and that's the presence of myocardial ischemia causing a depressed T wave. And then obviously you would get a troponin, an ECG, stress testing, and echo, just to see what's causing the underlying angina. The most common medications used for angina are vasodilators. The most common one is your nitroglycerin and is used to prevent coronary artery vasospasm and reduce preload and afterload. This is used to treat angina and help keep blood pressure under control. So when a patient takes nitro, sorry, when they take nitro, they place one under the tongue. They wait 5 minutes. If it's not relieved in 5 minutes, they're going to call 911. They're going to take another one. They can take up to 3 in 15 minutes.
It could be sitting in there, right?
Yeah, preferably, because it can tank your blood pressure pretty bad if some people just don't respond well to it. And then the most common side effect I've seen is headache. That's typically what people complain of. And then if they're on other type of like blood pressure control, it can have like profound hypotension. But if you're in the hospital setting and somebody comes in with chest pain, before you pop a nitro in their mouth, you need to get an EKG first, because if somebody's having an MI, depending on where it is, so typically they tell you not to give somebody nitroglycerin that's having an inferior wall MI, because where it vasodilates, it knocks out the preload of the heart and it just tanks their heart rate and their blood pressure, and you typically can't get it back. So some cardiologists like to use it, but it's definitely frowned upon in somebody having an inferior wall. And then if it's really bad, sometimes we'll go with like a nitroglycerin drip. And those patients typically do not like us, because if they're complaining of pain and their blood pressure is stable, we're titrating that drip up every 5 minutes. So it can be miserable for them. And then
You have to keep that tubing in.
so when you guys transition into the hospital, you're going to find that everything's an algorithm. Somebody comes in with chest pain, you follow this algorithm. You get an EKG, you get troponins. So acute coronary syndrome is essentially just a heart attack. So somebody's coming in, they have EKG changes, yes, they're having a STEMI. So typically, you're going to see ST segment elevation on your EKG. And then your other one, they're not having EKG changes, their troponin's elevated, they're having a non-STEMI. And then if their troponin's not elevated, they're having unstable angina. On your exam, you have to differentiate the difference between stable angina and a STEMI, what your interventions are going to be.
So STEMI in
Stable angina. So STEMI, obviously, they're going to the cath lab, and you're going to start them on a heparin drip. So heparin drips are all weight-based. So you'll give them a bolus infusion, so it's just an IV push, and then we'll start them on the drip. Typically, they stop it as soon as they get to cath lab, and then they restart it as soon as they get out of the cath lab. A non-stimming, so this is no SD changes at all. They just have an elevated troponin. They're going to be started on a heparin drip as well. Okay. All of this is going to tie hand in hand. So the main thing that we're learning about is coronary artery disease and how it's affecting the vessels. So the function of the vascular system includes supplying the circulatory needs of tissue, maintaining blood volume and pressure, providing capillary filtration, reabsorption, hemodynamic resistance, and peripheral vascular regulating mechanisms. So, assessment of the peripheral vascular system. Does anybody know what intermittent claudation is?
Where the arteries, you're not getting the blood flow back up where it needs to.
So,
Causes pain and
yes.
or can.
So this is when somebody says they start walking, and it typically occurs after a few minutes. Yeah, they get this leg pain. That's called intermittent claudation. That's a sign of coronary artery disease in the legs. And then physical assessment. Ruber is red skin. So I always say if you rub something, it's going to turn red. You're going to have to know this for obstetrics as well. If they have vascular issues, they're not going to have hair growth on their legs. Their legs are going to be pale. Sometimes they have like weeping edema, so the fluid's just coming right out of their legs. And then obviously you're going to want to do an assessment of their pulses just to make sure that they have adequate blood supply. Does everybody know where the pulses, what each pulse is? Because there are exam questions on this. So this is your popliteal, dorsalis pedis, and posterior tibial. You have to know these.
You have to know like the exact anatomy.
So this is the same as your coronary artery disease. You have to know your risk factors. So you have to know their health history, what their diet is, are they having claudation, are they having skin changes. These are all indicators that they're having vascular issues. Can you all see like the repetition in this? So if they have peripheral arterial disease, their arteries aren't getting blood low enough. So you want them to hold their legs below the level of the heart. If they're resting with their legs up, they're obviously not getting enough blood flow to the extremities. And then a lot of times the extremities are cold, so you need to heat them up. And then, do you know why we don't want them to use nicotine if they have arterial disease? Yeah, and then obviously stress reduction. And then if they have intermittent claudation, isometric exercises, this is like your squatting and leg exercises. It's not very extensive. That's what you would educate them to do. You need to know your modifiable and your non-modifiable risk factors for disease. I'm not going to sit up here and name them all. I feel like these are very simple to know. There is primary hyperlipidemia. That is one that you do need to put over here into the non-modifiable. This is a genetic disease. It's like 1 in every 250, somebody's just born with high cholesterol and they can't control it. So that's one non-modifiable. But everything else, they should be able to work on themselves to correct. So now I'm going to talk a little bit more in depth about peripheral arterial disease. This is a result from coronary artery disease that usually results in the arteries in the lower extremities and is characterized by inadequate blood flow. Atherosclerosis is caused by a gradual thickening of the empyema and media of the arteries, usually resulting in progressive narrowing of the lumen vessel. Plaques can form in the walls of the arteries, making them rough and fragile, with progressive stiffening of the arteries and the narrowing of the blood lumen supply to the tissues, and increased resistance of blood flow occurs. What's your risk factors for this? Smoking.
Inability. Not good.
Mm-mm. This is stuff that people are doing to themselves that are causing alcohol, diet, hypertension, diabetes, and hyperlipidemia. One thing that you guys will see on your exams is they call it sedentary lifestyle. So that is your like alcohol, smoking. Just note that because when I was in school, I was like, what is that? So just know that sedentary lifestyle, they're not living very healthy. So physical assessment findings, the patient will have rubor over the lower extremities, and they will have a bruit over the femoral and aortic arteries, increased capillary refill time, decreased or non-palpable pulses. That is a problem. That if they don't have pulses to the lower extremities, they're probably gonna lose that leg.
Is this the one that has like the darkened skin?
No, that's vascular disease. This has like a red pale skin.
Red pill.
And like,
Diagnostic test is an ankle brachial index. So ankle blood pressure is compared with the brachial blood pressure. So you'll take blood pressures in both legs, you'll use the highest one, and then you'll compare it with the arms. So an ABI should be 0.9 to 1.3. If it's less than 1.9, it is a great diagnostic test for determining peripheral arterial disease. And then if it's like 0.5, they're in like severe peripheral arterial disease and like the disease has really progressed.
And when you do those blood pressure
Yes, like this, like kind of just sitting.
With the leg drop.
Yeah, because so Raynaud's phenomenon, I actually have a few friends that have this. So this is a form of intermittent arterial vascular vasoconstriction that results in coldness, pain, and pallor of the fingertips and toes. The characteristic sequence of color change in Raynaud's phenomenon is described as white, blue, and red. Numbness, tingling, and burning occur as color changes. The manifestations tend to be bilateral and symmetric and may involve the fingers and toes. So we need to tell them if they have Raynaud's disease, they need to avoid nicotine and they need to avoid cold. So they need to avoid stressful situations that make them feel stressed and unsafe. They should practice stress management strategies that may help. And then cold exposure should be minimized, and the patient should wear heavy clothing in the fall and winter months. Now I'm going to talk about venous disorders. So this also plays an effect with arterial disease, and then Kevin, this one's more on the immobility side. So venous insufficiency occurs secondary to incompetent valves and deeper veins in the lower extremities, which results in pooling and dilation of blood vessels. These veins have the inability to carry fluid and waste from the lower extremities and participates in developing of swelling, venous stasis, ulcers, in advanced cases they can have cellulitis. So the physical assessment findings, you're going to see edema, and they'll have like this is the one where they have like the brown discoloration of the legs. So tell me what you think you're going to educate this patient to do rather than your arterial disease. So they have the arteries to get the blood down. So now it's all there. So now what are they going to do to get it back? They're elevate, compression stockings, things just to help pull the blood back. And then if they have an ulcer form, then they should have a dietitian consult and a wound care specialist, because if they don't get that healed, it's going to progress to something really bad. So your venous thromboembolism, this is a DVT, or a deep vein thrombosis, which is a blood clot believed to form as a result of venous stasis, endothelial injury, or hypercoagulability. So with a blood clot in the leg, it can break off and then go to the lung, and then that's a pulmonary embolism. These patients typically, if they have a pulmonary embolism, they have like the impending doom feeling, so they feel like they're going to die. A lot of times patients that come in as like a cardiac arrest due to a pulmonary embolism, like from here up is blue. And then that's how you knew that they probably threw a clot of some kind, and that's the result of a DVT. So with this, they're going to be started on a heparin drip. and heparin drip or a low molecular weight heparin, or that's the Lovenox shot that goes in the belly. That's weight-based. So heparin's weight-based, and then the Lovenox. So the Lovenox shots, they're pre-made, and the dose is depending on how much they weigh. They have a little air bubble in them. You guys need to make note of this. That air bubble you do not pop out. That's supposed to be there. If you pop it out, it can like alter the dose that the patient's actually getting. And then with your heparin drip, you're going to monitor an APTT level. This is the book says every 4 to 6 hours. It depends on what hospital you're at. We monitor it every 6 hours. So you monitor, it's a protocol. You monitor that level every 6 hours, and depending on what their PTT level is, will determine what dosage adjustment you need to make. So if it's too high, you're going to drop your dosage. So you'll just keep doing that until it's in a therapeutic range. And once you have 2 therapeutic levels, you will just do the blood draw every day while they're on therapy.
So whenever you make the changes, like say if you had to bump it up, you wouldn't check it sooner, or would you wait the full 6 hours?
So you'll wait so you get the 6 hours, you get your result back, and then you make your change, and then you order it for the next 6.
Okay.
So as soon as you make that change, that's when you reorder it. And then a lot of times when they're on heparin drip, they'll start them on a blood thinning agent like warfarin or Eliquis. So the main one that we're going to talk about is warfarin, and this is one that you have to monitor the PT and INR. And they have to have this monitored every month to make sure that they're in a therapeutic range. Warfarin takes a few days to actually kick in. So heparin's immediate. So they'll typically start warfarin while the patient's on a heparin drip. That way, whenever they get taken off, that dose is already therapeutic in their body, and then they can be discharged on that. So another important thing is you guys need to know the antidotes for these. So the antidote for heparin overdose is protamine. So if they develop they have a PTT that's like super elevated where they can't read it, you're going to give protamine just to stop that. And then on the long-term management of warfarin, the antidote for that is a vitamin K infusion. So on warfarin therapy, they also need to avoid like green leafy vegetables, things that are high in vitamin K, because that can decrease the effectiveness of the drug.
You know, say people shouldn't eat green leafy vegetables
To begin with, yes. And then ultimately to prevent DVT is early ambulation. So it commonly occurs after a surgery where patients are just laying around all the time. And then you just need to get them up and move them to get that blood moving. I just talked a little bit about this. So early ambulation, they need to have compression stockings. In the hospital, you'll see like stockings on their legs that squeeze every so many minutes. Lifestyle changes, they need to lose weight, they need to exercise, and they need to stop smoking. We're going to talk a little bit about aneurysms. This is a weakness in a section of a dilated artery that causes a widening or ballooning of a wall of a blood vessel this is called an aneurysm. Aneurysms can occur in 2 forms. They can be saccular, only affecting one side of the artery, or fusiform, involving a complete circumference of the artery. Risk factors include coronary artery disease, and this is the most common, uncontrolled hypertension, old age, and for younger individuals, if they use tobacco, that's the risk factor. So the most common one that I see in the hospital is your abdominal aortic aneurysm. and this is related to coronary artery disease. This is consistent with low back pain, pulsating abdominal mass, and bruit over the area of the aneurysm, and they will typically have an elevated blood pressure. Typically, we'll start them on like an Esmolol drip just to kind of help slow that heart rate down. And then the one that's really bad is your aortic dissection. This is, they describe it as a tearing sensation in their abdomen and back. It's a medical emergency. They have to go to the OR. Typically, they don't make it. Their aorta just tears. And from that, they develop like hypovolemic shock because they're bleeding like profoundly in their abdomen from that. So if somebody ever comes in with chest and back pain, you better be getting them to CT scan to see if they're having a dissection. We're going to cover a little bit on inflammatory heart disorders. So this is inflammation related to the heart is extended, and an inflammatory response often leads to destruction of healthy tissue. This is primarily includes the layers of the heart. So the most common ones that I've seen are your pericarditis and your infective endocarditis. So pericarditis is inflammation of the pericardium. It commonly follows a respiratory infection and can be due to a myocardial infarction or an acute exacerbation of a systemic connective disease. Findings include chest pain and pressure aggravated by breathing, coughing, and swallowing. A pericardial friction rub is often auscultated over the left sternal border. Shortness of breath is relieved with shortness of breath and pain is relieved by sitting and leaning forward. So they might have an elevated troponin with pericarditis. And then with this one, we commonly see this get mistaken with heart attacks because they have global ST elevation. So every lead on that EKG is going to have elevation in the ST segment. You need to know that. Myocarditis is an inflammation of the myocardium, which can be caused by a viral, fungal, or bacterial infection or systemic disease such as Crohn's disease. Findings include tachycardia, murmur, friction rub auscultated over the lungs, cardiomegaly, chest pain, and dysrhythmias. Rheumatic endocarditis is an infection of the endocardium due to a complication of rheumatic fever. This is preceded by a group A streptococcal pharyngitis. This is very common in kids. This produces lesions on the heart. Findings include chest pain, murmur, and friction rub. And then the last one I'm going to talk about is infective endocarditis. This is an infection of the endocardium due to staph, strep, or fungi. Many patients have a fever, flu-like symptoms, murmur, and petechiae. Infective endocarditis is typically seen in patients that use IV drugs. Yeah, their needles are dirty and then it just causes infection in the heart. If the patient goes to the dentist and they have infective endocarditis, they need to have prophylactic antibiotics prescribed just to prevent them from having complications. And then to treat this is we use penicillins, ibuprofen for pain, and prednisone for inflammation. So your essential hypertension, this is also known as primary hypertension, and this has no known cause. Like you just have hypertension with no rhyme or reason. And then secondary hypertension, this is caused by if you have another disease like renal disease, that's your secondary. So remember that. Primary is nothing's causing it. Secondary means something in your body is causing you to have high blood pressure. So if you have prolonged, untreated, or poorly controlled hypertension, it can result in peripheral vascular disease that primarily affects the brain, eyes, heart, and kidneys. So if they have hypertension, we need to be monitoring their kidney function just to make sure that it's not progressively getting worse as they have it. You need to know the classifications of hypertension. I'm going to give you exam questions that say they have this blood pressure, what category do they fall into? It's pretty cut dry, just remember the numbers. Your manifestations of hypertension, some patients don't know that they have hypertension. They just live with it and they have none of the side effects. But commonly, if it's high enough, you'll see headaches, facial flushing, dizziness, fainting, vision changes, and then nocturia. And then as it progresses, it can lead to cardiac hypertrophy, myocardial infarction, renal damage. So masked hypertension, this is when they go to a clinic, they have high blood pressure at home, but when they get to the clinic, their blood pressure is seemingly normal. They have no rhyme or reason of why this happens. And then white coat syndrome or white coat hypertension, this is they have normal blood pressure at home, but with the anxiety of the hospital, they develop hypertension from that.
We get that just from the clinic.
Yeah, hypertension,
I was like, listen, we're not that scary.
tachycardia, that's your white coat syndrome.
I had one that only had
So you want the patient to maintain a blood pressure of less than 120/80. That is normal. And then they need to participate in alcohol reduction, physical activity, decrease sodium intake, and then obviously reduce their weight. Okay, pharmacologic management. I'm going to hit the basics on these, and then you guys will watch the pharm lecture because that's what I did the voiceover for, because I know you guys are burnt out at that time of the day. So your first line treatment for high blood pressure is your thiazide diuretics. So this is your hydrochlorothiazide. This inhibits water and sodium reabsorption and increases potassium excretion. So what do we need to monitor for? Low potassium, muscle weakness, cramping, and then we'll learn in a few minutes if they have low potassium, they're going to have prominent U waves on their EKG. The same thing with your loop diuretics or furosemide. This decreases sodium reabsorption and increases potassium excretion. So for both of these, we need to educate the patient that they should increase foods that are high in potassium. So your bananas is a good example. They need to be eating this. Amlodipine is a calcium channel blocker that alters the movements of calcium ions through the cells, causing vasodilation, ultimately lowering blood pressure. So since it lowers their blood pressure, we need to have them change from a sitting to standing position very slowly because it can cause orthostatic hypotension. I always tell patients to, if they're on these blood pressure meds, just to kind of sit on the bedside for like 30 seconds to a minute, get the blood moving, and then they're good. So your ACE inhibitors, this is your prils or your lisinopril, captopril. This prevents conversion of angiotensin 1 and angiotensin 2, which prevents vasoconstriction. So with ACE inhibitors, we need for them to report a dry cough. This is common with therapy. So if they have a dry cough, we will change them from an ACE to an ARB. Another complication with ACE inhibitors is angioedema. So this is a medical emergency, and what's interesting about it is the patient might be on lisinopril for 7 years, and then all of a sudden they develop angioedema. They're going to describe it like they can't really get words out because their voice is so hoarse, their tongue swelling, their neck swelling. They typically come to the hospital, they get intubated. Your classic allergic reaction drugs like your your epinephrine IM and your Solu-Medrol don't work. So if it's too bad, they will crike them. So they will literally puncture a hole in their neck for them to get an airway. The one thing that I've seen used for reversal is fresh frozen plasma. You don't have to know that. I think it's more of a research thing at CMC to try to help with it. And the 2 cases that I've had, it did help. They didn't intubate the person.
We had a maintenance guy on our Stonewall in
Mhm.
Westwood. He was
If they have the dry cough with ACE inhibitors, they're going to switch them to ARB therapy. And this is your losartan. This is an angiotensin receptor blocker. And with this one, they can also have a cross sensitivity with ACE inhibitors because they have almost the same chemical compound. So these patients can still report cough, and they are at risk for angioedema. So if that occurs, we just need to get them off that completely. Spironolactone, this blocks aldosterone action. So during this therapy, the nurse should monitor kidney function, triglycerides, sodium, and potassium levels. They should advise the patient to not drink grapefruit juice or take St. John's wort, as it can cause adverse effects. And this one can cause hyperkalemia. So if they're trying to lower their blood pressure, they don't need to use salt substitutes because they typically have some type of potassium in them, and it can raise their blood pressure and it can cause them to develop hyperkalemia. So with hyperkalemia, with the hypo, you'll see prominent U waves on the EKG. This one, you're going to see peak T waves. So their T waves are almost going to be as tall as their QRS complex. And then that's a problem. Okay, beta blockers block the sympathetic nervous system and produce a slower heart rate and lowered blood pressure. This is not first-line treatment for hypertension. If you're ever in the hospital and they put you on a beta blocker for hypertension, it's not first line. They typically just use this for a high resting heart rate, but it can be used. So the nurse should monitor for blood pressure and pulse. So if the pulse is below, I think your book says 50, but in real life, 60. If it's below 60, do not give a beta blocker. You're going to cause more problems than what they already have. And then typically a systolic blood pressure of less than 110, you want to hold it. And then this is contraindicated in patients that have asthma because it can cause bronchospasms. And the last one, clonidine. This is used to reduce peripheral vascular resistance and increase blood pressure by inhibiting the reuptake of norepinephrine. This medication is not used first-line treatment. So typically they use clonidine as like a PRN basis. So if the patient's taking it at home and their blood pressure is 160, they're going to take a clonidine. So they need to monitor for adverse effects of this because it can cause sedation, orthostatic hypotension, and impotence. So commonly they use this as an off-label for ADHD and withdrawal symptoms. We're on our last two slides, and then I do need to say one more thing after this because I forgot. So hypertensive crisis occurs when a patient's blood pressure is above 180 over 120. This is a medical emergency. So they typically have blurred vision, dizziness, and disorientation, along with nosebleeds are commonly reported. So we were going to administer IV antihypertensive medications such as nitroprusside, nicardipine, and labetalol. Labetalol is an IV push. They typically give maybe 20 milligrams. You'll give it, and then it typically works, but it causes that rebound hypertension, and they typically need it on a drip. So if their blood pressure is that high, you don't want to drop it too fast. So you want to drop it with a goal of 20 to 25% within the first hour. All right. And then the last slide, this is what I wanted to cover. So this is what you would see in somebody that has hypokalemia. They have that U wave, and then this is hyper. We have medications for that, but if you're in the ER, you might see it. We give albuterol, calcium gluconate, insulin, and D10. It's an infusion. It pulls the potassium out of the cell, and you get rid of it.